Welcome to the deep dive, customized just for you. Today, we're tackling a really crucial class of medications, pulling key insights straight from your pharmacology text, anticholinergic agents. So our mission today is pretty simple. We want to understand how these drugs, fundamentally block the nervous system.
Right. What's the core action?
Exactly. And then what are they actually used for? We're talking everything from, say, a slow heart rate all the way to managing an overactive bladder.
It's a huge range.
A huge range. And most critically, we'll distill those high-stakes safety issues and the specific nursing considerations you have to know.
We are definitely diving into the world of parasympatholytic agents.
Yep.
That's the essential terminology here.
Parasympatholytic.
It literally means drugs that lies or block the effects of the parasympathetic nervous system. So if you think about the big picture, they're putting the brakes on our rest and digest system.
Which lets the fight or flight, the sympathetic system, kind of take over for a bit.
It lets it take center stage, exactly.
Okay, let's unpack this. I love the historical anecdote in the text because it perfectly foreshadows the effects. The prototype drug, atropine, it comes from the belladonna plant. And we're talking about a drug used centuries ago by European courts. Not for medicine, but just to dilate pupils as a fashion statement.
That history is just a perfect illustration of the drug's immediate visible action. And that action is defined by two key terms you need to know for vision.
Okay.
The first is mydriasis, which is that pupil dilation you just mentioned.
Right.
And the second is cycloplegia. That's the inability of the eye to focus on near objects, which, causes some pretty significant blurring for the person.
So if the effect is to block that whole parasympathetic system, what's the core mechanism? How does it actually happen?
The mechanism is actually elegant and very targeted. These drugs competitively block acetylcholine receptors.
Acetylcholine, or
Yeah,
wait.
exactly, AGA. But specifically at the muscarinic cholinergic receptor sites. By blocking AA, which is the main neurotransmitter for that rest and digest system, you prevent all the slowing and secreting it normally does.
So the sympathetic system, the one that speeds things up and dries things out, it just becomes dominant.
It becomes dominant, yes.
And this shift leads to that huge range of therapeutic uses you mentioned. The text really highlights how these drugs impact the system everywhere the parasympathetic nerve reaches. So what systems are we talking about?
Well, we can start with the heart. Here, we use them often acutely to restore cardiac rate or blood pressure if there's been vagal stimulation.
Or to treat a slow heart rate.
Critically, yes, to treat a dangerously slow heart rate or bradycardia.
And then there's the impact on the smooth muscle tracts.
Absolutely. Think of the GI and GU tracts. They're used to relieve spasms like pylorospasm or a hyperactive bowel.
And on the urinary side.
On the urinary side, they are essential for relaxing the bladder's detrusor muscle. This allows the sphincter to tighten just enough to treat conditions like overactive bladder. It's a game changer for those patients.
Beyond the tracts, the source material points out a lot of these sort of utility uses.
It does. Things like decreasing secretions before anesthesia or treating parkinsonism by balancing dopamine and blocking those stimulating A-She effects in the brain.
And motion sickness.
Motion sickness, right. Preventing vomiting. You're thinking of scopolamine or meclizine. And they can even be used as an antidote for specific types of cholinergic poisoning.
It's really worth pausing on the chemical specificity here, isn't it? The text notes that atropine and scopolamine only block the muscarinic receptors.
Right. This is why they have little, if any, effect at the neuromuscular junction.
Because that operates on nicotinic receptors.
Exactly. And that specificity is what allows us to create these more specialized, targeted drugs.
So let's look at how that specificity plays out in some of these specialty treatments.
Okay, good idea. We have agents tailored for the respiratory system. These are your inhaled agents, like ipratropium and its cousin aclidinium, tiotropium.
Humeclidinium.
Right. They cause bronchodilation and decrease secretions, which makes them cornerstones for conditions like COPD.
And then they're the ones targeted specifically for the bladder.
Exactly. For the urinary tract, drugs like oxybutynin, garafenicin, and sulfanicin, they focus almost exclusively on relaxing that smooth muscle of the bladder and ureter. They are highly effective.
We've seen the impact, the why. But before we treat anyone, we have to know how these drugs move through the body. Can you walk us through their disposition?
Sure. Pharmacokinetically, they're well absorbed, whether given orally or parenterally, and they are widely distributed.
And critically.
And critically, most of them cross the blood-brain barrier. And that wide distribution, especially into the CNS, immediately explains that wide range of systemic and mental side effects that we have to watch for.
Scopolamine is a great example of this, isn't it? often given as a transdermal patch. But there is a huge safety warning connected to those patches that nurses absolutely must know.
This is a high-stakes moment for patient safety, yeah. The source material highlights it clearly in the administration section. If a patient is wearing a dermal patch and needs a defibrillator or an MRI,
You have to take it off.
that patch must be removed immediately,
Why, though? That seems almost counterintuitive if the patient is in a critical situation.
because many of these transdermal systems, including scopolamine patches, have an aluminized barrier inside them.
Oh.
So if that's exposed to the high electrical discharge of a defibrillator or the intense magnetic field of an MRI, that aluminum can cause an electrical charge,
Leading to what? Burn?
leading to arsing, smoke, and potentially severe transdermal burns, not to mention a huge distraction during a critical procedure. It's incredibly dangerous.
That's terrifying. A tiny little patch designed for convenience could become a fire hazard.
The rule is crystal clear. Always remove the old patch, clean the site, and apply a new one to a clean, dry, hairless, and intact area. And if you have to manage hair, clip it. Never ever shave, because that can increase absorption.
We also have to think about sensitivity across the lifespan. Who is most at risk for these adverse effects?
We have to use extreme caution at both ends of the age spectrum. Children are often much more sensitive to the adverse effects.
Like confusion, constipation.
Exactly. Confusion, constipation, urinary retention. The text is very specific in cautioning that dicyclomine should not be used in pediatric populations at all.
And then you have older adults who are arguably the most susceptible to the really dangerous side effects.
Absolutely. They're highly prone to confusion, hallucinations, even full psychotic syndromes. But beyond the CNS, you have to remember they often have decreased body fluid and a reduced sweating capacity to begin with.
So you add an anticholinergic that reduces sweating even more.
And heat intolerance becomes a major, potentially fatal risk. Dose reduction is standard, especially if there's any hint of renal impairment.
And for pregnancy and lactation.
Generally, they're avoided. They can cross the placenta and have the potential for serious adverse effects, so you only use them if it's absolutely necessary.
This moves us right into the hard safety stops, the contraindications. If we're pushing the system towards sympathetic dominance, we have to identify any patient who's already at risk when things speed up or slow down too much.
Right, so the big question becomes, what pre-existing conditions could become life-threatening if we give these drugs?
Glaucoma has to be the first one. That pupil dilation, mydriasis, significantly increases intraocular pressure. It's a non-negotiable.
It is. And on the GI side, any condition where the bowel is already sluggish or obstructed is a huge red flag.
So something like a stenosing peptic ulcer or paralytic ileus.
Or toxic megacolon. Further slowing the GI activity in those cases is extremely dangerous.
And the same logic applies to the urinary tract, prostatic hypertrophy, or any kind of bladder obstruction.
Right, because the drug will just worsen retention by blocking sphincter relaxation and bladder muscle activity.
Yeah.
You're just making the problem worse.
We can't forget the heart.
No, because we're increasing that sympathetic influence, any patient with an existing tachycardia or myocardial ischemia is at very high risk. The increased heart rate could push them toward heart failure.
Okay, let's talk about the adverse effects. When you block the parasympathetic system, the body starts showing those symptoms everywhere. What's so useful here is the classic mnemonic that nurses have used for decades. It perfectly sums up the symptoms listed in your text.
Yes. The symptoms are often summarized as hot as a hare, blind as a bat, dry as a bone, mad as a hatter, and red as a beet.
Let's break that down with the source content. So, dry as a bone, that's the dry mouth, difficulty swallowing, and critically, that decreased sweating.
Blind as a bat. That's your blurred vision and photophobia.
Mad as a hatter is the confusion, hallucinations, the CNS effects.
And hot and red are those signs of impending heat prostration, all because the body can't cool itself down anymore.
This leads us directly to the absolute critical safety focus, atropine toxicity. This isn't just a list of annoying side effects anymore. This is a dose-related, life-threatening emergency.
It is.
So what does that look like clinically?
At a dose around, say, 5 milligrams, you see marked speech disturbances, difficulty swallowing, difficulty voiding, all made worse by that dry, hot skin.
But then if the dose hits 10 milligrams,
it escalates. Now the patient presents with a rapid, weak pulse, profound blurred vision, scarlet skin, lack of coordination, that's ataxia delirium.
And then coma?
And eventually coma. It requires immediate intervention.
And that's where the antidote comes in. Phasostigmin.
Physostigmin, which has to be given as a slow IV injection.
And because atropine has a fairly long half-life.
Right, and the antidote is metabolized much faster,
Yeah.
you often have to repeat the physostigmine dose,
Hmm.
maybe every hour or two, until those anticholinergic effects are clearly reversed.
Finally, we have to talk about drug interactions. It's not just prescription meds we need to worry about, is it?
Not at all. Combining these with any other drug that also has anticholinergic activity, and this includes common antihistamines, tricyclic antidepressants, MAOIs, some anti-Parkinsonism drugs, it just ramps up the risk of toxicity.
So patients have to be warned about over-the-counter cold or sleep aids.
Explicitly. They have to check the labels before taking anything.
Okay, so if we pull all this together, what does this mean for daily nursing management, for patient teaching? What are our assessment priorities?
The initial assessment is all about establishing a baseline and monitoring for risk. You have to get baselines for neurological status orientation, papillary response, and monitor vitals, especially pulse and BP. But you have to track GI and GU patterns.
Checking bowel sounds, tracking output,
Checking bowel sounds, tracking urinary output, and assessing for any bladder distension. It's crucial.
and implementation then focuses on managing those predictable side effects for dry mouth and GI issues.
Comfort measures are key. Sugarless lozenges, frequent mouth care, and making sure the patient is on a high-fiber preventative bowel program for constipation.
For vision and CNS issues, it's all about safety.
All about safety. Controlling room lighting for the photophobia, putting up side rails, and firmly telling the patient no driving or operating machinery if they feel confused or have blurred vision.
And for the GU system, you teach the patient to do what before taking the medication?
You teach them to void before taking the medication. It's paramount to preventing acute retention.
And back to that high-risk factor, heat intolerance.
You have to emphasize fluid intake and closely monitor their environmental heat exposure, especially when they first start a new anticholinergic.
Your source material provides such a powerful case study that ties all of this together. EK, a 64-year-old woman with heart disease, prescribed atropine for cystitis who's planning to travel to a warm climate.
It's a textbook example of high risk. The nursing concern here is immediate, and it's twofold. First, the drug increases sympathetic influence. That resulting tachycardia could put a huge strain on her already compromised heart.
Increasing the risk of heart failure.
Yes. And second, because she's traveling to a warm climate, that reduced sweating from the atropine puts her at an acutely high risk for heat stroke.
So teaching has to be really comprehensive.
It has to be. Avoiding temperature extremes, dressing coolly, maintaining maximum hydration, and knowing the early signs of heat prostration. She should have written documentation of her diagnosis and meds with her, too.
Let's recap the core takeaways from this deep dive. Anticholinergic agents are powerful parasympatholytic drugs that competitively block muscarinic receptors. While they offer huge benefits from speeding up the heart to calming an overactive bladder, their systemic effects are predictable, and at high doses, they mimic a severe overdose.
I think the most vital points for you to carry forward are recognizing that full range of systemic adverse effects, that mnemonic, hot as a hair, dry as a bone, is perfect, and understanding the critical risks. CNS confusion, the slowing of the GI and G systems, and that profound danger of heat prostration, especially in older adults.
And always assess for contraindications like glaucoma and GI or GU obstructions. Thank you so much for joining us on this deep dive.
We hope this provided you with the clarity you need to master this topic, really recognizing that crucial balance between therapeutic benefit and systemic safety.
And a final provocative thought for you to explore. If anticholinergics are sometimes used in very low doses for myasthenia gravis patients, not to treat MG, but to block the unwanted GI side effects from the cholinergic drugs they take, what does that tell us about the delicate balance between muscarinic and nicotinic receptor function and how targeted drug therapy is constantly evolving? Think about that as you continue your studies.